So it's now my pleasure to introduce Dr. Jill Conkin. Dr. Conkin is a professor of family medicine in the Faculty of Medicine and Dentistry at the University of Alberta. For the first 20 years of her career, she was a full-time rural generalist family physician. Since joining the academy, she's continued to work in rural communities, first as a locum for other rural generalists, and most recently sharing a position in a remote flying community in northern Alberta. Her work, both clinical and academic, is informed by the principles of social justice and health equity. Without further ado, I'll turn it over to you, Joe.
And thank you, Michael. Thank you so much for inviting me in. I'm a bit humbled to be following Christy and Fiona, whose work I love, and I also recommend the book. And I'm also, how should we say, a smidge anxious because I see a number of my rural colleagues online, so I hope I represent you well. I'm going to do a wee bit of theory at the beginning. I know I was to be talking more about rural health professionals and rural ethics, and I will get to that. But I think there are a couple of things potentially to add that will be helpful to understanding where I'm coming from. So I'm going to introduce the concepts of geographical narcissism and structural urbanism, and also how relationships are so important to clinical courage, which is a crucial piece of what rural physicians do, and we think all rural health professionals, but we don't have that evidence yet. So, conflict of interest. I'm a salaried faculty member at the Faculty of Medicine and Dentistry at the University of Alberta. I've received no funding for this presentation, but my real conflict of interest, for those of you who might be urban, is that I'm passionate about both rural communities and people, as well as health and health services delivery. Who am I? As one of our questioners earlier, I spent my early years on a farm a mile north of a town of 2,900 people at its height in the back of Beyond in Saskatchewan, and went to high school in a town 100 kilometers away of 10,000. I spent my first 20 years of practice, as Michael said, as a full-service generalist family physician with enhanced skills, especially in surgical obstetrics, but with some surgery. I've continued to work as a locum, and I've been involved in health service delivery and rural medical education for my entire career. So 2018, Malin Fors, who's a psychoanalyst in the far north of Norway, published a paper that spoke to me in major ways. That and she called the concept geographical narcissism, identifying a lot of what Fiona and Christy have just talked about, that power is in urban, that's where privilege is, that's where the norms are set. And urban throughout the world exploits rural and remote, both for resources and agricultural production. And while 30% of the GDP or more, depending on the country, comes from rural and remote, not much of that goes back into those communities. And interesting, and this feeds well into what we were just talking about, visiting urban professionals, she poses the question, are they colonizers or rescuers? And I would argue they're both, depending on the context. And that there are very important things beyond what Morley was talking about trust, but being sure that you're not de-skilling the local people and professionals, that you're not giving the message that somehow they're lesser than you because you come from the city, those kinds of things. And clearly she talked about the othering, again, that Christy and Fiona talked about, that, rural is either the sort of country bumpkins or the redneck anti-vaxxers, or the idyllic pastoral place where everybody would like to be but can't be, sort of thing, which allows, no matter which way you go, allows it to be dismissed and ignored in many cases. and then the implicit urban moral superiority from our urban populations. And oftentimes not intentional. It's just assumed that urban is better. And because there are more of them, then that seems to be the dominant ideology. Structural urbanism comes from a study in the States that was mostly about the financing of rural health. And Janet Probst and her colleagues looked at how the bias was to large centers and also to the individuality of care, as opposed to seeing rural as a population-based system that needed resources that were different and often sort of more per capita, for instance, than what was coming to urban. And that these ideas of, sort of urban people looking at problems everywhere and assuming urban solutions can be imposed on rural and be successful is often not the case. And so that's the baked into all of the structures that we have in health service delivery and the various practices of the various professionals, et cetera. And then all of this disadvantages rural populations. I won't spend much time on this because Christy and Fiona have, but sort of coming to this understanding that the ethics that I subscribe to do fundamentally come from feminist ethics that are relational and contextual, and that they are concerned with power, and power in relationships, power between individuals. And I didn't put it here, but I think it's really important. I don't talk about healthcare systems. Feminist ethicists usually talk about care as being, it's a one-to-one, it's a heart-to-heart thing. Our systems can create the environment in which we can care, but they don't care. And so I think, again, language is hugely important. And we kind of get ourselves mixed up in some of that. Also, ethics being relational and contextual then are obviously based in community and connection, in particular in rural. I do agree with one of the final comments that there are circumstances in the city where some of this sense of community and belonging and whatever does exist, and that we do have to recognize that and work together over some of those things, but that so much of rural ethics is its own. I'm going back to Malin Fors again, because in 2013, she published an article called Potato Ethics, and why potato, and she's Swedish but works in Norway. And I've got a quote from her there, that the Swedes look at potatoes as a humble side dish, plain, useful, versatile, and compatible with any main course. And it's her thesis that most rural health professionals are that, versatile, humble, able to work with anybody in any circumstance, but sort of seen as plain and kind of something that doesn't stand out. She also talks about potato ethics is also very much based in feminist ethics. And so it's relational, and the foundation is the ethics of care. That would be Toronto and Gillian's work. So she posits that the ethics of health professionals in rural would be towards making oneself useful, being accountable in the community, and not just as a professional, being pragmatic or versatile. And then she used this interesting word, working to prevent discontinuity. And in looking further into that, what does she mean there? Compensating for lack of staff. So there's only 3 of you in the rural ED at 11 at night, an LPN, an RN, and you. And the LPN and RN are a bit busy. Someone else comes in. So you start to get them clerked in because that will help everybody. These days with new EMRs and stuff, it may not be as easy to do. But even just getting a blanket for somebody or whatever can be an important piece of being part of a team. I'll come to clinical courage in a bit, but essentially that means working to the edge of your scope, your skills, abilities, and knowledge in service of a patient. And then assessing the circumstances like distance and weather. And my example there is that whenever I was called because one of my patients had gone into labor, once I'd assessed the laboring patient, I made it my business to, especially if it was winter, look at what the weather was going to be. Was, how many Winnebagos were on the road between Hinton and Jasper, because Hinton was our bailout if something went a bit awry for a lot of this time. We didn't have C-section capabilities. Anyway, and so those would be things that would be beyond what other professionals in urban would be looking at. And so that's part of, but a small part of, fully connecting to the context, knowing your resources, both personnel and financial, knowing the circumstances, knowing the patients, knowing their families, all of that sort of thing. So considerations. So the relationships. I think the key piece here is honoring trust and connection. And as was stated earlier, dual relationships are unavoidable in rural. Even in the, how shall I put it, even in the transactional world. Okay, there was a point at which I was in the city at a conference and one of my rear windows was bashed out. I managed to paper it over to drive for the 350 kilometers home. But there were only 2 garages in town, and both of them were run by patients. Well, I had no choice but to go to one of them. Going out of town just wasn't an option for me for that. And I think what urban people have lost touch with, maybe, I don't know, or maybe they just have other relationships that they don't need to think about these things, is that not all relationships are transactional, in the sense I give you something and I expect something back, which is what so much of the gift work is done on. And I'll come to that later. Confidentiality. And thank you for the example of your mother as a nurse, your dad as someone involved in the community, and your dad mad at not knowing who was in hospital and what was happening. There are times with families you can work out some differences in confidentiality, but always with the patient's permission, unless they're not able to give permission, and then you get the alternative decision makers' views on it. But if you're going to have people trust you with some of their most painful secrets and moments, then they need to know that you won't say a word unless they permit it. You can't be a rural professional in a rural community without participating in the community, without having some friends. You can't just stick with family. It will drive your family crazy, but it will also not be good for you. And so we come to boundaries. And this is a really sort of interesting negotiation for rural health professionals in negotiating how you understand the context and the relationship and where your boundaries are. I'm adding clinical courage just because it's practicing at the edge of one's scope. And like I said, we know a lot about this for rural physicians. We think it's true for other rural professionals, and we're about to do that work. But the 6 characteristics were sort of standing up to serve your community, accepting uncertainty and persistently seeking to prepare, deliberately understanding and marshaling resources in context, humbly seeking to know one's own limits, clearing the cognitive hurdle when something needs to be done for your patient, and collegial support to stand up again. We did another look at our study with a very different lens, and published another paper about the importance of relationships. And I'm just going to read this little piece. Key finding was that clinical courage was impacted on by the relationships rural doctors had with their communities and patients, first and foremost, and then with each other, with local members of their healthcare team, and with other colleagues and health leaders outside their immediate community of practice. Further study has shown 2 big concepts functioning in the system, which seems obvious, but responsiveness to the community and mutual trust is one of those elements. And that's patient-physician, but also community-physician. When physicians feel their communities support them and feel they will do the best for their patients and for the community, much more likely to feel comfortable moving to that uncomfortable place of working at the edge of your scope. So rural realities. You are in a fishbowl. Everybody knows everybody, and they certainly know who you are. And they know where you live. And they even know if you have some, sort of regular things that you do, where you will be on Wednesday night if you're not on call. And so that all becomes part of a mix. And how is it that you live in this fishbowl and live your life? Sort of, there are ways. I mean, sometimes one just needs to leave town. For me, luckily, because I lived in Jasper, sometimes that would be backcountry skiing for a few days. But sometimes it would need to be a couple or 3 weeks out of town to completely disconnect. And I put in quotes the next one because this comes from a story that an urban emergency room doctor told me. He was caring for a man in the emergency room who was there with his daughter, and don't know the circumstance, but he and the daughter got talking briefly. Turned out she was from Jasper, and he said, "Oh, did you know Jill Conkin?" And she said, "Oh yeah, she was one of my friends." And he said, "Friends?" And she just blurted out, "Well, every doctor needs friends, don't you know?" But I've already said this, that the health professionals need a social and community life beyond family. And certainly if they're single professionals, that's even more important and a little harder to negotiate. And the one boundary that I think is absolute is the standards about sexual relationships with patients. Health professionals are often looked to for leadership. And again, it makes you even more visible in your community if you're in that circumstance. Resource constraints. The urban structuralist financial policies have severely constrained resources available. The mention of the latest changes in our health system. I've been involved in rural health delivery for 3+ decades in this province. And every significant change to the system has meant that rural has lost significantly. And it's often that view that, oh, well, we'll just have these services in urban communities because they'll be better quality or whatever. And we do know that it is quite possible to have a broad scope of services closer to home, closer to rural people, if we only attend to it and see and get beyond the idea that health services are only a cost center, as opposed to they're an economic driver in rural communities. And not only that, they bring professionals to the community, which adds to the vibrancy and brings in other businesses and industries and whatever. So hugely important. Health human resources are scarce. I lived and worked and survived the Klein blowing up the system with no plan in the 90s. And this feels worse. And there's a meanness in the background to this that one didn't feel in the same way during Klein's time. And then we work in a system that's not a system. And I fear there's going to be even less a system with the new organization, but we'll leave that. But this is only one example, and I'll have a couple of others later. But of late, because the city is pressed in different ways, but is also scrambling because there aren't enough health professionals in the city, there aren't enough beds in our hospitals or in our emergency departments, etc. And so it's becoming more common for rural docs to be calling for help with critical patients, to be told, no, there's no room. And what does that then do for, how shall we say, not just the ethics, but the moral distress and moral injury that rural health professionals are struggling with? So I have a few situations to kind of give you some ideas of how some of these ethical things, belonging and relationships, fit with rural health professionals. And then I think we're going to have plenty of time to have questions and conversations. So this was early in my career, and I'd been up most of the night attending a delivery. And once the paperwork was done and everything, it was about 9 or so, and that's when the deli opened, and I thought, oh goody, I can stop in for a few goodies to make a nice breakfast before I go to bed. And so I walk in, and the person who owned the deli and worked behind the counter was also the husband of one of the nurses I worked with. And you know, usually a really friendly kind of guy and whatever, but not a word, not a hello, not a good morning, not a nothing, just, well, what did they have? And I thought, okay, what do you mean? Well, we know that so-and-so's car was at the hospital overnight and your bike was noticed there early this morning. So assume that so-and-so had a baby. I said, oh, maybe they did, maybe they didn't. Well, you know, what was it? And we had quite a tussle about why I wouldn't tell him. And, you know, I'm going through, am I just being, because it wasn't, how should I say, I grew up in a small place, so I knew a lot of this sort of thing just because, but here I was in a circumstance that I hadn't been in before, and there wasn't anything in my training that helped me with this. And so I'm thinking, okay, so what would happen if I did tell him? And then I thought, okay, so if I did, then that really is, you know, is that just an idiotic boundary or is it not? And I thought, okay, so if I'm willing to tell someone this, when I really think it's the parents' joy to tell friends and neighbors that they've had a baby, what the sex is, etc., what their names are. But if I tell people this, where will I stop? What will my boundary be? So I decided that, you know, this was the right thing for me, and just sort of kept at that as my own personal thing. And that sort of bled into a few other things that I'll come to in a minute or two. Of course, one of the, I think nurses and doctors in particular, but I suspect some of the other health professionals also get this. You know, you're looking at the broccoli and someone comes over and says, well, can I ask you about whatever? And again, sort of figuring out where your boundaries are, what you're willing to do. For a good part of my 16 plus years in Jasper, I did 1 in 3 call. So I was very available. And when I wasn't on call, I didn't want to be thinking about medicine. I needed a break, a mental break. And so I decided that I wouldn't deal with personal medical issues no matter what, unless someone fainted in front of me on the sidewalk or whatever, that I wouldn't do that. And so I had reasonably nice ways of doing it. You know, people come out and say, well, you know, did you get my blood test back or whatever? Well, of course, you're not going to know that necessarily. But I just sort of say, you know what? When I closed the door of the clinic, I turned Dr. Conkin's brain off. And you don't want to be talking to this brain. Clinic's open tomorrow. Happy to see you then. Give the clinic a call and we'll fit you in somewhere. Or something to that effect. That it once, how can I put it? You need to be clear about what you're doing. You need to be pleasant and not rude. But you need to be consistent. And that was a lesson I learned early in my career that held me in good stead for how to deal with these things. A kind of funny anecdote from this is I was walking down the street with some family and friends, and someone is running behind us going, Dr. K, and waving. And I turned around, and it was someone that wasn't a patient of mine, but that I had seen in the ED a couple of days before. I have a question for you. And I shouted back, I don't work on the street. Well, of course, everybody I was with just collapsed in laughter. And you kind of go, Gad, I guess I better be careful what I say. That might have a double meaning here, but I think he got the message. About halfway into my time in Jasper, the person that I worked with for all of that time, and the other doc in town, who did come to work with us ultimately, we decided there was a huge gap in women's reproductive health services, and decided, and this was long before the abortion pill, we decided that we would work on getting a program to do therapeutic abortions. It was something I'd been trained to do, was willing to do. My colleague was the anesthetist, and he was willing to be part of it. Some interesting things. Our hospital had been a Catholic hospital, but was no longer, but of course had some of that tradition behind it. And one of our best nurses was violently, well, not quite violently, vocally opposed to abortion. She had a brother who was violently opposed to. He belonged to one of the organizations that would do not very nice things outside of abortion clinics in Canada and the US. And we talked a lot about that, and would we do this, and why might we do this? And there was clearly a need in our area. And so we went ahead. And what was painful but ultimately helpful in my understanding of this is the nurse who was, I mean, there were some other people who were opposed, but I mean, she wrote me a very strong letter that was very personal. We had included the nurses as we were building the process, we being the nurse in charge and the docs involved and the administrator, and made it clear that nurses who had a conscientious objection to this would not need to be involved in any way, all of those kinds of things. But she was, sort of made it very clear that she was very disappointed in me and whatever. But what was comforting to me over the next 4 or 5 years is that we actually worked out a working relationship, that we were in the same community, It was a small community, and the health team was a small health team, and that even something that was that controversial could be overcome by continued dialogue and respect. I said I'd come back to this. Transferring seriously ill patients has gotten quite a bit easier of late, in that in the old days, you used to have to call every single hospital and talk to the doc on call for whatever discipline you needed. And then you might get turfed and sort of said, no, we can't take them, or we don't have beds, or whatever. And then you'd have to call the next hospital and say the same thing over again. And sometimes that was 3 or 4 or more times. And now we have a central way of doing that, a number for the north and a number for the south. But as I said earlier, there are now many, many more circumstances where colleagues are dealing with critically ill patients that the person on call for the service for rapid, which is what this triage, central triage is, are saying we don't have beds. And Australians have done some really useful things and are way ahead of us in some ways. But they passed a law years ago where referral centers could not turn down rural docs asking for help with a patient, to transfer a patient. And yet now there are docs telling docs there's no room. And I think that's an ethical issue for the urban docs. And somehow that needs to be worked out and figured out, because I don't think physicians should be telling their colleagues that, no, we can't help you, even though we have more resources than you. But the other things here are, you have someone critically ill. And thank you, Christy and Fiona. I remember, Christy, when you first spoke at the SRPC, Society of Rural Physicians of Canada meeting some years ago, and talked about people being displaced when they were transferred from their rural community. And, you know, there's some thinking one has to do. You know, if someone is so critically ill that the likelihood they're going to die on the way is there, how do you have those conversations with them and their family? Because you never know for sure. And, you know, sort of advocating, you know, yeah, I want to go. Some people don't want to go, you know, even if I'm going to die, I don't want to go. And then you have to kind of go through the, you know, risks and benefits and all of those things to make sure they really understand, and if there's family with them and they want to have that conversation with family, that you have that conversation with them. But you sort of need, you need a lot more understanding of how to navigate those critical circumstances and what it would mean to a patient to die in transit. And that if they've chosen to go, and that's what you're afraid might happen, then you're often the doc advocating for, you know, please can we send their partner or their oldest child or whatever with them so they're not alone. And it's been interesting, you know, that again, here are, well, you know, there'll be no room and whatever. And it's all about, again, the transactional things rather than the relational things. And how are we taking care of that person that we're trying to get to a place that would give them the potential of a chance at living longer and a good life longer, but also taking the risk of sending them all or dislocating them all by themselves, with the chance that they might die alone. And so I think that there are crucial pieces here. And also, you know, some ethical issues. I never did it, but there were times before this central triage in particular when I would be talking to somebody who is about to say, no, can't take them, no beds. And I just want to say, you know what, oops, I think the ambulance has just left. Now, I wouldn't do that because I think that's unprofessional for my colleagues. But I remember vividly a 4 a.m. conversation with a specialist in the city who I had. So I'd always, in the old days in Edmonton, there was a airport near the Royal Alec Hospital. And so when we were transferring by air, we would try to get them there. Well, I'd been turned down there. So I tried the university hospital because that was the next closest. No, turned down there. So I then tried the hospital at the edge of the western edge of town. And that was a hospital we often used for, if it was a road transport or for patients who were urgent but not critical. And got hold of someone that I knew. And we went through the story. So this is the third time I've told the story. And he said, Jill, we do have a bed, but we don't have the staff. And then there was a pause. And then he said, you know what? That's not your problem. That's mine. And I know I have a couple of hours to work it out, so send them. And I just felt so relieved that there was someone who actually understood that I could no longer care for this person, and that I did need that kind of help. And so there's still a lot to be desired in the relationships in the system. Consequences for patients' friends, very quick tale. Out for coffee one, I think it was a Saturday morning, doesn't matter. And someone who was kind of at the edge of this circle had been admitted to hospital 2 or 3 days before that. And there were a couple people at the table kind of talking about it. And I, of course, had my mouth shut. And one of my good friends kind of finally pitched up and said, what are you talking about? And they said, well, blah, blah, blah. And, how come I don't know? And then it was their view. They sort of said, okay, I get it. I'm so tired of this. You all assume, because we're good friends, looking at me, that I know things about people in the hospital. So you don't tell me. She doesn't say a word. Her lips are zippered shut. And so I know nothing. I'm not even part of the town gossip. So stop it. Get me back on your list. Anyway, so there are consequences to friends of health professionals as well, kind of like the husband of the nurse in that small village in Alberta. And finally, something that often comes up, and it's all around gifts. And some are so obvious that you're not going to take them, or at least not personally, even though, I think about it, we had lots of tourists, obviously, and generally speaking, German tourists would want to tip you, even though they paid, they'd want to tip you. Well, no, I don't take money. You've already paid me. No, this is what we do. And it became such a difficult thing. What we did was we talked in the office and we decided we'd have a coffee fund jar that bought snacks and coffee for the staff and whatever. And that was our way of dealing with that. Even though if you think about it, these would be people that we would see once. So paying, and not that I wanted the money, but that paying the doc wouldn't buy them better care, which is often what is assumed, that you give somebody something and you expect something back. But things like, and obviously muffins and food and whatever could be shared with others. But I think vividly of a patient that I had who was a wonderful gardener, and I loved gardening. And we would often, in our little bit of social time, sometimes in our times together in the clinic, would talk about gardening. And then she'd bring me a couple of her prize carrots or whatever. Well, this could get me in trouble with my professional group, but I wasn't going to give those carrots away, because I would give her something back that I was proud that had come up this year or done something or whatever. That was the friend piece of things She didn't expect anything from me, and I didn't expect anything from her. It was just these things happened. And so coming back to relationships and context, it's hugely important that we have some gray room, that it isn't just, you don't take anything from anybody ever. And I think that there are ways of negotiating that so that you don't end up in a situation where it was intended to be transactional. That's the huge piece there. Anyway, I'm going to stop there. I'm at 40 minutes. That's what I was told I'd have. And I'll turn it back over to you, Michael.